Hello, everyone. Welcome. Today we'll talk about HIV and the nervous system. My name is Dr. Mtete. I'm a consultant neurologist at Livingstone University Teaching Hospital in Zambia. So the slides that I'm using today are actually borrowed from my mentor and teacher, Professor Diana Sela. And I'm so thankful to her for allowing me to use these slides. Our talk today will cover the effects of HIV infection on the nervous system. And this is purely disease of the nervous system resulting from HIV infection. And it will not include opportunistic infections in HIV disease or any other related diseases that are associated with HIV infection, for example, stroke. And so for simplicity's sake, we will discuss these conditions based on the level of the neural axis that is affected, as well as the time frame in which the disease occurs. So this is divided into three parts of the neural axis, that is the brain, one, two, the spinal cord, and three, the peripheral nerves. Now, I should mention again that this is an oversimplification because the neural axis obviously has more levels than what has been mentioned here. Again, based on the time frame, acute infection means within 90 days. Late infection, when the patient has got a CD4 of less than 200 cells per mil, and anything in between is regarded as any time. So we will fill this table with diseases that are a direct consequence of HIV infection. So for acute HIV infection, you have one, on the brain, septic meningitis, and two, on the peripheral nerves, cranial nerve cell palsy, also called Bell's palsy, and acute inflammatory demyelinating polyneuropathy, AIDP, whose eponym is GBS. And you also have CIDP, which is the chronic version of AIDP. This is where the symptoms keep progressing after 8 weeks of onset. Conditions that happen anytime during the HIV infection include one, motor neuron disease, which affects the spinal cord, and at the level of the peripheral nerves, you've got brachial plexopathy, also known as Parsonage-Turner syndrome by its eponym, and you've got dystosymmetric polyneuropathy as well. The late effects include HAND, which is HIV-associated neurocognitive impairment at the level of the brain, and then you've got vacuolar myelopathy affecting the spinal cord, and again, peripheral neuropathy. I should mention that peripheral neuropathy has got multiple causes in the setting of HIV, and so it may be impossible to completely attribute it to HIV infection. Some ART drugs can cause neuropathy, and so can other comorbid conditions that occur in the setting of HIV, including nutritional deficiencies. So we'll start by talking about those conditions that occur in the acute setting of HIV infection, that is within 90 days of HIV infection. And to start this talk, I want to highlight a paper that was published by Helmuth et al., in which they sought to determine the incidence, timing, and severity of neurological findings in acute HIV infection, that is pre-antibody seroconversion, as well as persistence with combination antiretroviral therapy. So they basically recruited HIV-negative individuals who are at high risk for infection, and they tested them with ultrasensitive rapid HIV tests and viral load every 2 weeks. So they were able to pick the actual time or period in which an individual got infected with HIV before seroconversion, and they followed them up afterwards. So the table shows neurological conditions that people reported in the first 90 days after their HIV infection. They recruited 139 patients who were predominantly male, and more than half had some sort of neurological condition in the first 3 months. So we can see that neurological manifestations, even in the acute HIV infection setting, are quite common. Conditions that were reported included problems with concentration, cognitive impairment, memory problems, speech, gait, upper limb coordination impairment, voluntary abnormal movements, involuntary abnormal movements, so to say, and slowed responses. Then on the neurological exam, they were able to pick up some abnormalities, which included problems with smooth pursuit, problems with saccades, limb strength, digital deep tendon reflexes, limb coordination problems, and gait abnormalities. And except for neuropathy, which was high throughout the period of follow-up, you can see that some of these were quite rare. When the UPDRS exam, that is the United Parkinson's Disease Rating Scale, which is done because there is a lot of basal ganglia features in HIV dementia, which is a subcortical dementia. They found a good number of patients with slowing. So you can see, like on this table, finger tapping was slowed in quite a good number of patients. And so this study highlighted that neurological manifestations are quite common even in acute HIV. And so when we see patients with acute HIV, we must endeavor to try to bring out some of these neurological problems, as we can miss them if we don't seek for them. And so I'll go straight to the acute manifestations, the neurological manifestations of acute HIV infection. And I'm going to start with aseptic meningitis. So these patients will present just like any other meningitis with non-specific headaches, neck stiffness, with or without fever. But because this is happening on a background of acute HIV infection, these people may have flu-like symptoms, which may include muscle and joint pains, and so on. When you do CSF studies, there may be an elevated protein and lymphocytosis, but no organisms are found on examination, and cultures are negative. But remember, in HIV infection, there is a chronic inflammatory process on the CNS, and there may be a mild elevation in white cell count. So from about 0 to 20 cells per mil, that can usually be found in someone who's got HIV. Imaging is usually normal, and for these patients, treatment is just supportive. The second one is the Bell's palsy. So Bell's palsy is a very common manifestation in early HIV, and there is no way to differentiate it from other causes of peripheral cranial nerve cell palsy. So if a patient presents with Bell's palsy, you may want to test for HIV. If it's negative and you still have a high index of suspicion, these are the kinds of patients you may want to do a viral load to confirm that actually there is no HIV. Then we move on to GBS. So GBS is very common in acute HIV. It usually presents in an acute to subacute setting, that is within hours or days or a few weeks of presentation. And the pattern of disease progression is normally ascending numbness and weakness that starts from the feet and then climbs up to the knees and beyond. In the wake-up for GBS, you want to do a lumbar puncture, and what you're looking for is cytoabdominological dissociation, which is, so you don't find any cells, but there is raised protein. The only caveat here to remember is that in HIV, like I said earlier, there is usually a chronic inflammatory process going on the brain. And so you may find a very mild leukocytosis of about 0 to 20 cells. And if it is not out of proportion as compared to the kind of level of protein you have, then you want to consider this as cytoabdominological dissociation. Treatment is usually using IVIG or plasmapheresis. In the same vein, we can talk about chronic inflammatory demyelinating polyneuropathy, which is the same as AIDP, except symptoms are slightly slower in terms of onset, and then progression goes beyond 8 weeks. Treatment here will include IVIG, but you can also use steroids here. I should mention that steroids in AIDP are actually contraindicated. So that is also another difference in terms of management. Okay, so this table shows other conditions that have been associated with acute HIV. And so here you can see additional conditions like cognitive dysfunction, acute demyelinating encephalomyelopathy, meningoradiculitis, transverse myelitis, and optic neuropathy, some extrapyramidal signs. And so all of these situations can also occur in the sense of acute HIV infections. And I think these are some of the things you should keep in mind. So for acute demyelinating encephalomyelopathy, you diagnose this using MRI and CSF, and treatment is using steroids. Meningoradiculitis. So like the way HIV will cause AIDP and CIDP affecting the roots and the nerves, it can affect the roots and then also affect the meninges to cause the meningoradiculitis. And so you will need EMG and nerve conduction studies where you will see demyelination. Treatment here is just supportive. Transverse myelitis in the setting of HIV should only be considered the etiology after you rule out other things, and the investigations are unrevealing. And here again, you use steroids and IVIG. In case of optic neuropathy, this can be unilateral or bilateral, but it is quite rare. You have to rule out the broad causes of optic neuritis before you can attribute the optic neuropathy to HIV. And the treatment here also is, again, steroids. With regards to extrapyramidal signs, which include tremors and bradykinesia, you give supportive treatment. So let's move on to diseases that occur anytime during the HIV infection. Motor neuron disease it's a rare manifestation of HIV infection, and the way it presents is very identical to ALS, which occurs in people who are not HIV infected. Motor neuron disease in the setting of HIV is called HIV-associated motor neuron disease. Like I said, presentation will be identical to ALS, and there is no way of telling them apart. It commonly occurs in people with high viral load who are pre-ART, and goodness with it is got potential to reverse, or the progression may stop once you start ART. And so this is, I think, the one situation where someone would hope the patient they are seeing who has got motor neuron disease has got HIV, because once the ART is started, these patients will either show a reversal of their symptoms or the progression of the disease will stop. However, I should mention that for someone who has got HIV and develops the normal type of ALS, this wouldn't respond to the initiation of ART. And so these are the ones that you may see that the symptoms keep progressing. So the next condition is vasculitic neuropathy. This is a rare kind of neuropathy, and this presents with mononeuritis multiplex. So mononeuritis multiplex involves large named nerves, and the deficits the patient will present with will be within the distribution of the named nerve. This is very painful, and the pain is usually out of proportion to the findings you find on the neuro exam. For the diagnosis, the workup will include nerve conduction studies, an EMG, and sometimes muscle and nerve biopsy. Treatment will include initiation of ART. Sometimes you may have to initiate immunosuppressive agents as well to control the vasculitis, but of course this has to be done in conjunction with an infectious disease specialist, because remember, these are patients who are already immunosuppressed, and giving more immunosuppression drugs may present more problems. Next up is brachial plexopathy, so which is also called Parsonage-Turner syndrome. So brachial plexopathy presents with significant pain in the shoulder and arm for about 1 to 2 weeks. So this initial pain is a deep aching pain, which occurs in the first 1 to 2 weeks, which after which they then develop the typical neuropathic pain and also weakness within the next 1 or 2 weeks. This usually is an idiopathic process and is not caused by any infection besides HIV. It is usually a monophasic process and is usually unilateral, but can be bilateral. So you may want to think about it. And of course, you may want to have differentials like motor neuron disease when you deal with a disease like this. Treatment is important. The treatment is supportive with a steroid taper. You initiate combined antiretroviral treatment, and you also give supportive treatment for the neuropathic pain. You may want to give agents that work for neuropathic pain, for example, pregabalin, gabapentin, and amitriptyline. CIDP, peripheral neuropathy, these can also occur anytime throughout the course of the HIV infection. And because we mentioned these in the acute setting, but they can occur also anytime during the HIV infection. And lastly, we are going to discuss the conditions that are associated with late infection. So as we mentioned, when CD4 is less than 200 during HIV infection. And so I'll begin with HIV-associated neurocognitive disorders. The diagnosis is based on formal neuropsychological testing and the level of functional impairment. One must first exclude confounding factors, including learning disabilities, drug abuse, psychiatric illnesses, neuro or CNS infections that may impair cognition, for example, neurosyphilis, before one can attribute the cognitive disorder to HIV. And cognitive impairment is a spectrum, and it includes asymptomatic neurocognitive impairment, which is also referred to as ANI. This level has got minor deficits on neuro psychological testing, and it does not affect the functioning of the patient. Then next in the spectrum is minor neurocognitive disease, also known as MND. Here there is moderate deficits on neuropsychological testing with minimal effect on daily functioning. And so for these two, ANI and MND, you'll find that these diagnoses are usually made after probing by the clinician. And so most of the time they'll be discovered in the setting of studies where you are using a tool to try to pick out some of the minor or moderate manifestations of neurocognitive impairment. Then HIV-associated dementia. So this shows moderate to severe impairment on neuropsychological testing and has significant effect on daily functioning, activities of daily living, etc. This slide shows how the epidemiology of HIV-associated dementia, that is the severest form of hand, has changed in the ART era. So before ART, about 40% of patients would develop HIV-associated dementia, and this would progress until they died. In the ART era, however, only about 5 to 10% develop HIV-associated dementia, and there is very frequent improvement when patients are put on ART. However, the mild forms of hand have remained pretty much the same to the previous levels. But one thing I think that is important here is to note that adherence drops markedly when people have cognitive impairment. They also report trouble communicating, issues with finances, shopping, etc. And the other thing that has been noted in terms of the pre-ART and the ART eras is the type of dementia that occurs now. So clinical features of HIV-associated dementia have also changed. Initially, there was prominent subcortical dementia, but in the ART era, it is mostly a mild phenotype of mixed cortical and subcortical dementia. And so what are the risk factors for HIV-associated dementia? One is older age. So the older someone is, the more likely that they may develop HIV-associated dementia. So things like low CD4, high viral load, which are markers of poor HIV control. These are also risk factors for HIV-associated dementia. Other AIDS-related symptoms or infections. The low level of platelets and anemia are also associated with HIV-associated dementia, but this is not well understood as to how it poses a risk to that. Then conditions like depression are also associated with HIV-associated dementia, but this is a bit difficult because it cannot be known which is which, as in is the depression causing the dementia or the HIV itself, or the dementia causing the depression. So it's a bit difficult to attribute one to the other. Then conditions like apolipoprotein E, which is also found in Alzheimer's, this also poses a risk. In terms of diagnosis, so screening by administering the HIV dementia scale, which is an HIV-specific dementia scale, and it looks at the domains that the cognitive domains that are commonly affected by HIV. Anyone who gets a score less than 10 is referred for formal neuropsychological testing. Of course, you would need to rule out confounding factors, like we mentioned, things like drug and alcohol abuse, CNS infections that may cause dementia. You may have to rule this out. The MRI may help in terms of ruling out other conditions, but also it may show you the typical picture that is seen in people with HIV associated dementia. And so the next slide is going to show us an MRI of someone with HIV associated dementia. What I should mention is that the MRI will normally show symmetric subcortical T2 and flare hyperintensities, which are patchy or confluent. There's usually no enhancement when contrast is added, and there is no mass effect. So like you can see on here, this shows T2 and flare hyperintensities in the subcortex region. You can see them in this region. This is the T2 image. And then on flare, you can see still there is this T2 more or less confluent hyperintensities. But you can see you don't see any edema. You can see the sulci very well, the ventricles very well. They haven't shown the contrast images, but there is no contrast as well. Okay, so with HIV-associated dementia, treatment will involve treating the modifiable risk factors. So, for example, those taking drugs, taking alcohol, there is need for proper counseling to stop taking these drugs. If there are CNS infections that pose risk to causing dementia, those need to be treated. Of course, there should be initiation of ART, and then there is supportive management, so caregiver support, then cognitive therapy with a speech and language pathologist, increase daily activities with exercise and social stimulation programs. Then regarding peripheral neuropathy, so this is the most common form of this is the most common condition that affects HIV infected patients, and about 35 to 50% of patients with HIV will get peripheral neuropathy. And like I mentioned earlier, this could be due to the direct effect of HIV on the peripheral nerves, but then there are ART drugs that cause peripheral neuropathy. So it could be HIV versus the ART or any other comorbid conditions. HIV has been shown to have a direct impact on oligodendrocytes, and then ART, especially the older drugs like stavudine, didanosine, were also responsible for causing neuropathy by their effect on the mitochondria. It is impossible to differentiate etiology on clinical or electrophysiological basis. ARV-associated neuropathy may be more painful, more abrupt in onset, and may progress rapidly, but this is not always. I think one thing that may help one associate the neuropathy to the ART is the temporal association. But then some people may develop the neuropathy way after they've started the ART. So this is not really important because the treatment is basically the same. So the same supportive treatment given for HIV-associated neuropathy is the same that will be given when someone has got neuropathy because of ART. But of course, if there is a close temporal relationship, you may consider stopping the ART and giving alternative drugs that may not cause too much of the problem. In terms of presentation, so this mostly presents as distal sensory polyneuropathy and is slowly progressive. It presents in a length-dependent fashion with a glove and stocking distribution. It normally presents with positive symptoms, so that is things like aching, painful numbness, burning, pins and needles, and it usually involves sensory more than motor symptoms. These symptoms are usually most severe at night or after walking on soles of the feet. Weakness, generally not a predominant symptom, like I mentioned before. Motor involvement can be seen late in the presentation. The hands are rarely not involved, but for some people, by the time the symptoms are reaching the knees, they may have started developing some symptoms in the hands. Risk factors for peripheral neuropathy include age, low CD4 and high viral load again. So other factors like alcohol, neurotoxic drugs, nutritional deficiencies, other things that already pose a risk for peripheral neuropathy. So conditions like type 2 diabetes, chronic kidney disease, hepatitis C virus, these are the things you actually may want to look for. Neurotoxic drugs include the HIV drugs you're using, the antiretroviral drugs, and drugs being used for comorbid conditions, like if you're using isoniazid to treat TB or for TB prophylaxis, then these potentially can cause peripheral neuropathy. In terms of examination, so there is decreased pinprick and temperature sensation in the affected areas, then there is decreased light touch and vibration, which can occur later. Reduced or absent ankle reflexes, like mentioned earlier, weakness is rare or maybe a very late manifestation. Diagnosis, so clinical diagnosis is usually enough, but then you can do some ancillary tests, so EMG and nerve conduction studies. But then one thing to remember is that EMG and nerve conduction studies may be normal because these are very small nerves that may not be tested by nerve conduction studies. In some centers, they may do a skin biopsy to look at the density of the epidermal nerve fibers, but then this is a test that is only available in some hospitals, and so it doesn't have much utility in clinical setting. In terms of treatment, so number one is to obviously remove the offending agent if possible. If you can pick something that has got a temporal relation with the development of the peripheral neuropathy, like the ART drugs like isoniazid, then you can remove these. Then modifiable risk factors, things like optimal control of type 2 diabetes, making sure chronic kidney disease is treated, hepatitis C virus is treated, avoiding alcohol, and normalizing B12 if there are such nutritional deficiencies. So in terms of dietary modifications, we may consider adding vitamin B complex in these patients with limited diets. Then avoid diets like those involving cassava, which may have some neurotoxicity. Neuropathic pain medications may help, and these include drugs like pregabalin, gabapentin, lamotrigine, amitriptyline. Some topical agents can be used like capsaicin and lidocaine patches. Narcotics can be used, but one thing that should be remembered is neuropathic pain is very difficult to treat, and sometimes you may have to try one and the next drug before someone can have something that they actually respond to. So let me highlight this study that was done by Prof. Sela in Uganda on peripheral neuropathy. So they wanted to determine the prevalence, risk factors, and functional impairment associated with peripheral neuropathy in a prospective cohort of adults in rural Uganda. And basically what they found in this study is that peripheral neuropathy was found to be about 3 times more common in HIV-infected patients compared to their HIV-negative counterparts. Of course, other risk factors that were associated with high risk included the use of neurotoxic drugs. And so here you can see the relative risk, almost 2.8 for those that are HIV positive. And then for those that had prior neurotoxic drug use as well, about two times more. Let me now talk about vacuolar myelopathy. And so vacuolar myelopathy is usually a late manifestation in HIV. It usually occurs after the development of AIDS. Pre-ART, about 5 to 25% of patients, 25 to 55% on autopsy were found to have myelopathy. Survival after diagnosis is usually less than 6 months. In the ART era, less than 10% of AIDS patients. So the way it presents with slowly progressive lower extremity weakness, stiffness, and sensory loss. These patients have got gait difficulties and imbalance, so they've got spasticity, which usually causes scissoring of the limbs, and this causes a lot of gait difficulties and imbalance. They have sphincter dysfunction. Then there is the upper extremity involvement, but only as a late feature. On examination, upper motor neuron findings will be there, and they're almost always symmetric. There is usually no sensory level in these patients. Of course, for myelopathy, you need to have a very wide differential. So when you've got someone presenting like that, other things to consider are infectious myelopathy from viruses like HSV, varicella zoster, and CMV. TB myelopathy, of course, has to be included, CNS lymphoma, HTLV1, spinal epidural abscess, especially in those who are IV drug users, compressive myelopathy, for example, from TB spine, nutritional and other causes of myelopathy. So things like B12 deficiency, and especially because a vacuolar myelopathy presents with more posterior cord symptoms, things like B12 deficiency should be considered. And I think also we should consider tertiary syphilis as well. Tabes studies may affect the posterior cord as well. So the workup, of course, you need to do a lumbar puncture, but CF studies are usually bland. When the MRI is done, it shows non-enhancing T2 hyperintensities, often affecting the posterior column. And so this MRI is a T2 MRI showing hyperintensities in the cord from about C2 to somewhere C5, and you can see it looks like it's mostly on the posterior aspect of the cord. And so in these two MRI images as well, you can see in the longitudinal picture, it affects the posterior part. The hyperintensity affects the posterior part of the spinal cord, and a cross section shows you also that it affects the dorsal column. On histopathology, so there is vacuolization of the spinal cord. Basically, what happens is when the neurons die, they leave these vacuoles. So hence the name vacuolar myelopathy. Treatment is ART, and of course supportive treatment with physiotherapy and occupational therapy. But basically, you can't replace the nerves that have died. So for most of these patients, there may be no improvement in terms of the deficits that they already have. Other supportive treatment may include treatment for the spasticity. So you may want to give some antispasmodics like baclofen. And so this ends our discussion on the acute, the manifestations, the neurological manifestations in HIV. Thank you very much for listening.